Okay. No one's willing to jump in, so I'm assuming just you can let us know after the meeting or shoot us an email, and we will get started. So welcome everyone. Today is Wednesday, March 10th. During the pandemic, I always have to, I start each day reminding myself of what day of the week it is. It doesn't come naturally anymore. Just want to run over our agenda with you this morning. We're going to, welcome and introductions, of course, we'll start with. I want to give a brief, some brief comments about our Medline partnership and talk about the value to your practices of considering participation with that new program. We're going to spend a lot of the meeting talking about our new PCP Reward Plan, and this will be replacing the incentive plan. Kevin, can I ask, are you able to let folks in from the waiting room? Or do you have co-host ability? Okay, yep. Great. All right, then I will stop paying attention to that then. Thank you. So we're going to do Kim Povak and I will be doing a dive into the PCP Reward Plan, and we're going to then do an introduction for you to the Provider Engagement Report. And this will be replacing the Triple Aim report. We want to run through that with you, and we have Bob Kiso with us from URMC Information Systems Division. Has a lot of background in user experience and especially in running focus groups. So he's going to lead us through a facilitated discussion so we can get some feedback from you on the usefulness of this new reporting tool, the Provider Engagement Report. Willie Newdigant is going to give us an update on the 2021 quality measures, and then I'm just going to run through what are some of the upcoming incentive payments. So with that, let's get started. As far as welcome introductions, I'm Renee Sutton. I'm with AHP and Director of Provider Network Management and Payer Relations. Kevin Kelly is on the call. He's our Provider Relations Liaison. Kim Povak, the Director of Finance for the CMO. Christy Howard, our Director of IT. Mark Cronin, our COO, is on the call. Willie Newdigant from ISD. Elizabeth Sharp, our Director of Performance Optimization. We have some folks from Care Management. Daryl Sharp is here. A lot of our care managers are on the call. Anyone else from the AHP team missing, I am sorry. Welcome, and we're glad that you're with us this morning. And then we also have some new practice managers who are joining us today. So I want to welcome to our group Tracy June from Irondequoit Pediatrics, Tracy Sterner from Wayland Family Practice, and Catherine Zutch from, I hope I'm saying that right, Catherine, from Brighton Pediatrics. I know you ran us through how to pronounce your name before, but I just asked Willie Newdigant. It takes me a while to master these things. So we want to welcome our new folks to the group, and we hope that you find this a helpful forum for you to learn more about AHP and some of the value we're hoping to deliver to your practices. So I'll just get started with reminding folks of the Medline partnership. So we had Chris Earle from Medline attend our meeting, our last meeting, which I believe was in December, to talk about a new relationship with AHP. And Medline is a manufacturer. It works with ProVista, which is a group purchasing organization. And the net effect of our relationship with this organization is giving AHP participating private practices access to some fantastic, super favorable pricing on PPE and other medical supplies. In fact, it's the same favorable pricing that Medline extends to UR Medicine with their tremendous purchasing power. So this is going to be available to all AHP practices regardless of specialty. Our pilot practices saved on average about 28% on the cost of their medical supplies. We think it's going to be, and one thing I found interesting in a recent call with Medline is that when they do a cost analysis with hospitals for this same kind of work, the savings that are enough to move a hospital to move this to Medline is in the order of 3%, 4%, and a hospital will move their business for just for that degree of savings, 3 or 4% of savings. Our private practices, our pilot practices, on average, we're saving 28% on the cost of their medical supplies. So we think there's a real compelling case here for you to give Medline a chance to earn your business and for your practice to experience these amazing annual savings. Signing up is super easy. You just need to contact your Medline rep, Jennifer Taskin. I'll have her contact information on the next slide, and we can send that out again. She's going to do a pricing analysis on your most ordered supplies. Once you're contracted, you're going to get access to the Medline ordering system. Everything about this process is designed to make it easy for you to sign up and to get you access to this pricing and these supplies as soon as possible. They're really committed to not, getting you all excited about 28% savings and then saying, oh, it'll be about 2-3 months. It's a much more accelerated timeline to get you connected and get that supply chain established. And you're going to enjoy better access as well, in addition to the great pricing, better access to the supplies and the services you need. So we hope that you'll consider giving Jennifer a call. Her information's down there on the bottom left, jtaskin@medline.com. She also hopefully has reached out to many of you, and we think you're going to find this a great opportunity to save your practice some money, and just another way that we hope at AHP to deliver value to our private practices. Any questions about Medline or anyone on the call who'd like to, Kim, I see you've unmuted, but let me just ask if folks on the call have had any experience yet with Medline or anything they'd like to say. I know that they've reached out to some of our practices already. Okay, Kim, what did you want?
Yeah, I was just going to add, I've been working with Renee on this for several months now. And when we did the initial pricing analysis, that 28% average savings was simply using Medline's pricing on the things you're currently buying now. And practices experienced more savings if and when they decided to specifically go along with Medline products, so purchased manufactured products from Medline, and those savings were upwards of 36 to 41%. We recognize you all have things in your practice that folks are comfortable using, but just to say the opportunities are there if it's something you're interested in pursuing, and they've been great to work with. So again, please reach out to Jen or Renee and I with any questions or concerns.
Renee, I'm wondering if I could also just chime in quickly and add to your and Kim's comments. As Renee has indicated, this is certainly voluntary. You're free to take a look at it and take advantage of it, or not look at it or not take advantage of it. We just think it's, as Renee said and Kim has indicated, a really good opportunity. I know when I ran a practice before I came to AHP, someone had said you might be able to save 28% on something. It certainly would have caught my interest, but it's totally voluntary, as we've indicated. One of the things to know too, AHP is not getting any commission or anything out of this, so please know that we're not plugging it based on that. It's really, this aligns with our mission, as Renee said at the end of her comments there. Our mission is to support the providers in our network and with financial and other resources, and we just thought this is a great opportunity to get you access to pricing that the university has. So hope you'll take a look at it and take advantage of it, but obviously it's voluntary, and we think it's a good thing.
Thanks, Mark, and thanks, Kim. Mark and Kim have been, absolutely, they really have worked diligently with UR Medicine and Medline to get this stood up and quickly contracted and made available to you. So 100% kudos to them for getting this available to our practices. So with that, I will move on to our agenda topic, our new PCP Reward Plan. So we want to walk you through, I have a little mini agenda within the agenda. On this topic, we want to first talk about how our network earns gain sharing, just level set to make sure everyone understands how we earn gain sharing. And then, because that's important, right? Because how we earn gain sharing, that's how the money flows into our organization. So it's important that our providers display the behaviors and activities that we need them to in order for us to earn those rewards through gain sharing. Then we're going to take a look at we're going to go over what the prior incentive plan for primary care was to help you, get the context of the prior plan in order to understand how this new plan differentiates. And then I'm going to turn it over to Kim to do a deep dive into this new reward plan. And she's going to do it as well, introducing elements of that new provider engagement plan, because that's going to be our reporting tool that's going to help you understand your provider's performance to the things that we're incentivizing. And we think there's just some really exciting new things about our provider engagement report. I'm going to talk about a new element of our PCP reward plan, and that's citizenship. And then we're going to turn it over to Christy and then Bob Kiso for that facilitated discussion to really get your feedback on this new provider engagement report in order to make sure that the tool is going to be useful and helpful for you and for your providers. And obviously, we want your feedback as well on the reward plan. As you have questions, please throw them in the chat, and we'll also pause at the appropriate moments and grab your questions then. So with that, I'm going to get started, and we're going to start with talking about how our network earns gain sharing. And I like to kind of equate the gain sharing equation with the healthcare value equation, right? Value in healthcare is an expression of quality over cost. That is how we express the value in healthcare. And very similarly, how we earn gain sharing is based on quality and cost. We only earn gain share when we hit quality targets and perform under the budget. In fact, I really ought to fix this slide to say we only earn gain share when we perform under the budget and hit quality targets, because performing under the budget is key. We have to save money in order for us to earn any gain sharing. So that's the equation, right? It's quality and it's cost. But you'll notice that how we've been incentivizing our primary care providers, that equation has just been quality. PCPs have earned incentives based really only on their quality performance. So this is a little grid that shows over the years how our PCP quality incentive plan has changed. Version 1.0, we paid an incentive to providers and practices. And we did it based just on the point capture in the Arcadia dashboard, and over and under. You earn 50% or more points, you earn the max. Below that, you earned a base incentive amount. Version 2.0, we went to provider only, but it was still an over-under. It was still just based on those quality measures in Arcadia. We upped the thresholds. It went from 50% or more to earn the max to 65% or more of points to earn the max. And then version 3.0, the current plan under which we're living, we introduced a gold level. So to reward superior merit. So for practices earning 90% or more of points, they would earn the gold level. Silver and bronze are the point captures that you see on the screen. And then we also introduced an improvement bonus for providers who were demonstrating just 20% or more improvement over the prior year, a way to recognize that kind of really exceptional achievement and improvement. But again, as you can see, even though our gain sharing equation is cost and quality, the PCP incentive was based solely on their quality measures. Similarly, gain sharing is another way we incentivize our providers and our PCPs, and that methodology was based on quality and attribution. So I'll talk about what the gain sharing methodology, how that's evolved over the years. When we first started out, PCPs who participated in all of our gain sharing contracts were awarded a base amount. That was the same amount per PCP, and then an attribution amount, an amount based on the number of lives that they brought into the network. They received a per member amount. When we started out, it was based on the lives that were covered under contract. If we earned gain sharing under Excelis, you earned a per member amount on your Excelis membership. Version 2.0, we tweaked that a little, and we went to a base amount, an attribution amount, but an amount per member, an amount per life on your panel. So regardless of insurance coverage, we were paying you a per member amount on all the patients on your panel. And then a quality component. The quality component equals the quality incentive amount that we paid. So what I talked about in the earlier slide, this incentive plan, this we were paying in March. Gain sharing, we pay August, September, and the quality component of gain sharing was the same amount that we paid you in March. So it was a duplicate payment. So over our years in AHP, even though all along, and we've been in gain sharing contracts since 2013, 2014, our network is rewarded based on our performance to cost, saving the system money, beating those budgets, and hitting quality targets. But the way we've incentivized our PCPs has solely been on quality, and then also there's an attribution element. So what our goal is in this reward plan that we are presenting to you today is to better align our PCP incentives with that gain sharing equation, to base those payments on quality and cost performance, because cost performance is important. It's what gets us to be able to earn gain sharing. So with that, I want to turn it over to Kim to go into the deeper dive of what we're calling our new PCP Reward Plan. And I'll pause too if there's any questions at this point. Okay, I'll turn it over to Kim.
Okay, wonderful. Thank you, Renee. And as we go through this, please put any questions you have in the chat or just voice them. We'd be happy to chat about them right now. So when I think about some of the changes coming to the PCP Reward Plan and our provider engagement report, which we'll talk about just a bit later, there are three main changes, and Renee has outlined several of them already. The first big change is that instead of 2 payments, we're going to take those 2 payments, put the pools of money together, and provide 1 payment in September. The second big change is what we're actually rewarding. So as you all know, we've been rewarding based upon quality. Now we'll be adding in a cost component and a citizenship component as well. The third big change is the addition of the provider engagement report. And the provider engagement report will replace the triple aim report. The triple aim report used to come quarterly. It was a paper copy that we used to send out. And while we received wonderful feedback on it in terms of the information is really helpful, it's visually displayed quite nicely, the one big piece of feedback we received was that it wasn't actionable. People wanted patient level detail, and this provider engagement report will allow us to do that. I think the other important thing to mention while we're on this slide too is the provider engagement report, the PER as we call it, doesn't happen without our reward plan, and our reward plan doesn't happen without our provider engagement report. So what's in the provider engagement report is what we're rewarding PCPs on, and what we're rewarding PCPs on will be in the provider engagement report. We wanted to make this very clean and clear about what these 2 components were doing and how they interlinked. The last 2 bullet points here is also important to note. So as you all know, when PCPs bring attribution to the network, AHP receives clinical integration dollars, or a PMPM, that we pass on a significant portion of that to all of you. So as we think about lives in the network, we have some providers who bring 61 patients to the network, whereas we have other providers who bring 2,000 patients to the network. And of course, that means a different amount of clinical integration dollars flowing through AHP. So part of what we had to model in here was that PCPs or providers who brought 500 or fewer patients to the network would max out their quality component at the silver level. As Renee explained in the previous slides, we had a silver and a gold level. So again, these providers with 500 or fewer attributed lives will max out at the silver component. I'll also say that we've modeled this out, I think, 6 or 8 different ways now. We wanted this to be fair and reflective of the work that folks were really doing. And so part of this was looking at a provider who brought a lot of attribution to the network, but was maybe a poor performer, or a provider who shot up, who was a super good performer, but maybe had low attribution. So we wanted to reward everyone based upon what they were bringing. And we really feel like this has gotten us pretty close. Of course, we're here today to get your feedback. Given that this is going to get rolled out in 2022, so providers will not be incentivized based upon this model this year, but 2022 starting in January. So we're really taking this year to get your feedback. We want your feedback on the data that you're seeing, on how it looks, the provider engagement report, and the incentive plan overall. Any questions about the big meta changes before we move on? Okay. Thank you, Renee. This pictorially describes what Renee and I have shared thus far. The timeline on the top represents our old reward plan and the intervals at what it used to pay out. So as you can see, when you compare the old reward plan to the new reward plan, which is on the bottom, those quarterly clinical integration payments are still there. That's not going to change. What will change is this quality incentive. And so this quality incentive right here is not down here. What we've done is we've taken this quality incentive and combined it with our gain sharing payment, and we've created one payment, which is this PCP reward payment. And instead of it just being based on quality up here, it's going to be based on quality, IPCs, and pharmacy. So IPCs are integrated practice committees. And we borrowed this phrase from Baylor Scott and White, a large health system in Texas. And these IPCs, they were characterized as utilization-driven initiatives with financial underpinnings. They were also characterized as initiatives that the health system couldn't do alone, or a practice couldn't do alone, or AHP couldn't do alone. But it was an initiative where we had to engage the whole healthcare system. So an example of an IPC is our 5-contact readmission program. And so we're going to start rewarding based upon some process metrics for our IPCs, our pharmacy. And then lastly, I remember my first one-on-one with Renee here at AHP, she emphasized how part of what she wanted to do was incentivize citizenship. And so 4.5 years later, that's coming to fruition based upon the new changes to this reward plan. So it's really exciting to see. And I believe in the next slides, we're going to get into the actual breakdown of what this is going to look like. Wonderful. Thanks, Renee. So before, 100% of our reward plan was based on quality. As you can see here, what we've done is we've split it out. So instead of 100% being based on quality, we're now going to reward 60% quality, 30% for IPCs and pharmacy, or those cost-based initiatives, and 10% based on citizenship. For the quality component, this is going to be reflective of what you see in Arcadia. One thing we will note about the provider engagement report, and I also just want to give a huge shout out to Christy and her team. What you're going to see here in the next few slides is just completely impressive. This provider engagement report is customizable. It really focuses in on where a provider has opportunities, and the amount of flexibility that Christy has been able to build in it's been a game changer for us, and we hope it'll be a game changer for you, your practices, and your patients as well. So this quality measure performance will be based out of Arcadia. We do recognize that most of your practices do pre-visit planning and gap closure out of your EMRs, which we fully expect to continue because of the efficiencies there. So this component may be a little delayed by the time you see it. The data may not be as up to date, but what we're really looking to do is we want this provider engagement report to be directional. We want you to be able to pick this up in your practice and your providers to pick this up in your care managers and say, oh, gee, we're knocking it out of the park on quality, but you know what, we could all do a little better on this pharmacy initiative or the 5-contact readmission program. And that's where we start moving into some of the more prospective looking initiatives. We want this to be actionable. To us, if this isn't actionable, it's no better than that triple aim report. And so that's where some of the pharmacy items, some of the IPCs will become more actionable with patient lists that one can take a next step on. And then the last component, 10% will be paid out on citizenship. And Renee has 2 really great slides at the end that she is going to dive into and really talk about what that means. So again, instead of 100% being based on quality, it's going to be 60% quality, 30% cost performance, and 10% citizenship. Great, thank you, Renee. Internally, we have come to refer to this provider engagement report as the PER, hence the CAT. So again, I've actually covered quite a bit of this already. It's going to replace that triple aim report. I'll just re-emphasize how this is going to be customized. And we're going to dive into that in 2 slides. So I'm not going to spend a whole lot of time on that right now. It'll be distributed quarterly and it'll be snapshots. These will be snapshots in time that we hope over the long term will become very prospective looking. Wonderful. So this is the face sheet of the provider engagement report, or rather the first thing a practice or a provider will see or a care manager will see when they log in. Bob is here to talk to us and really ask us questions about the layout, the format, and the technical design of the provider engagement report. So my job here is really just to parallel our provider engagement report and our reward plan. So I'm gonna save all the technical questions for Bob and the layout questions designed for Bob. What you see here in the red box is the cost versus quality grid. And this is what Renee was talking about in the beginning. This is value. This is value-based care. This is, This is high quality care, doing it in a cost-effective way. And so I believe we shared with you our cost quality grid, but this is really the beginning of the provider engagement report. And this is really what sets the stage for the rest of the PER. So what you can see here is we have cost on the y-axis over here, so total cost of care, and we have quality on the x-axis down here. So as you've probably figured out, this is the ideal state. This is where we want practices to be. This means that they're a high quality performer, but they're also a low cost performer. And so each practice will be identified and compared to other practices. The other practices will be blinded. So you'll just see where you compare to other practices who are not being aimed. So in essence, if I'm a provider and I log in and my dot is up here, what this tells me is that I'm not doing great on quality because I'm down here, 25th percentile, and I'm pretty expensive. So my provider engagement report will be oriented around initiatives that will move me in this direction. So ways I can improve my quality performance and ways I can improve my cost performance. If you're a provider out here, what this says is you're knocking it out of the park on quality. However, your provider engagement report will be aimed with initiatives and be focused on initiatives that help us reduce costs. And again, over here, you get where this is going. A low cost provider, we would want them to work on quality to improve their quality performance. And this is really what drives the rest of the provider engagement report. Thanks, Renee. So what we want to do now is mirror that 60-30-10 and what this is going to look like on this face sheet. All of these areas you can click into more, and Bob's going to dive into all of that. But the quality piece will be represented based upon your Arcadia quality measure performance. So what you see here as quality measures. And then the other item is Elizabeth came to us while we were creating while the team was creating the provider engagement report and the reward plan. And she said, hey guys, we oftentimes have specific optimization team initiatives that we're working on. It'd be great if we could incentivize part of that. And so what she proposed is that, if we do have a specific quality measure we want to make special and incentivize in a special way, that she would take 10% of this quality component and apply it towards whatever quality initiative her team is working on. So we simply use depression screening as an example. We're not sure if that'll be there in 2022, but it's really just a placeholder for whatever Elizabeth and her team says is the appropriate quality measure. And so 50% in this case would then be based on quality out of Arcadia, and 10 would be based on the specific quality measure initiative. If we go to the next component, the Ipc and Pharmacy, this is the cost component. Again, this will be tailored around your practice, whether it's family medicine, internal medicine, or pediatrics. The cost initiatives will be reflective of that. We're not going to ask a pediatrician to do the post-acute care initiative. It just doesn't make sense. It's not something they have any influence over. And if a 7-year-old was in your denominator, we'd have other problems we'd want to figure out. But I say all this to say it'll be appropriate. We want to reward people for the good work that people are doing. We're not trying to trick people with any of this. So the other thing we think it's important to say too is if you're questioning your denominators, come talk to us. We want this to make sense. We want the data to be reliable and trustworthy. And we also realize this isn't going to be perfect in the beginning. So we want to give ourselves 2021 to really launch this and to get your feedback. But as you can see, this highlights pharmacy, this highlights readmissions, one of our IPCs we're working on the adult side, and pediatric LARC, which is an IPC on the pediatric side as well. And I think one more click, Renee, citizenship, and Renee's going to dive into this pretty in detail on the next several slides. But what I want to reemphasize here is simply that the quality, IPC, pharmacy, and citizenship, that's what is in the PER. And what is in the PER is what we're rewarding. So there's not going to be something on the PER that we're not going to reward, and we're not going to reward something that we're not going to show you something about. Yeah, so great question about readmissions. So this goes back to, I think I mentioned it earlier. We can't reward providers based on a readmission rate. If you're a provider who lives outside of Monroe County, my guess is that you may not have a ton of patients being discharged from Strong or Highland, and your denominator may be very small, and you may have no control over if that patient gets readmitted. So rather, these are going to be process-based metrics. We have a 5-contact readmission program. And it'll be based on context. So it'll be based upon areas you have an area of control, said differently. We also have to take into account here for the 5-contact program, which hospitals are participating or are not participating. So this will be primary care rather than hospital-based. Does that answer your question, Jeff? Do you want to say a bit more?
Yeah, I don't know. Sometimes it's frustrating because the care in the hospital, and I think Thompson's a good hospital, but the care in the hospital is not what I would do.
Yeah, sure, absolutely.
And the care in Highland and Strong is not what I would do.
Yeah, so part of that, the other piece of this is going to be conversations with Chad, our medical director. And Chad is going to be doing visits with each of the practices. And this would be a great topic of conversation. How do you reconcile that? How do we reconcile that? And that's a place that I would point to discussions with medical directors. I'll also say, Jeff, I'm not sure if this helps at all. Right now, the 5-contact program is running out of Strong and Highland, and is active for practices with embedded care managers. So we also realize not everyone has an embedded care manager. And so this would not be an initiative.
We have an excellent one, but you know, I just gave up in-hospital care relatively recently, and it's very frustrating for me, but that's, you know, what can I say?
Well, let me, if I can, Kim, maybe let me add to Kim's answer. I think I think this is a good example, but in some ways it's a challenging example. I think the notion here on citizenship is engagement. Kind of said differently, what we don't want to do is have, our providers and our whole value here of Accountable Health Partners is we have a group of outstanding providers who are cost-effective, providing high quality care to folks. And so we want people to be engaged in the network in a meaningful way. So I look at this one as more, it's about participating in the initiatives that we have that are applicable to the work you do. Kim makes a mention to, if Chad Teeters, Dr. Teeters is our executive medical director, wants to visit with your practice, that you're receptive to that if we're interested in working with you in a pharmacy initiative, that you're receptive to that. So really it's about engagement and hoping not to have people who are disengaged. And that's really the notion on the citizenship one.
So I want to address some of the new questions in the chat. Regarding our mid-levels going to have their own PER, or will it all be under a physician? We're going to kick off, we're planning kicking off initially with just physicians, but absolutely those enrolled APPs are, bring attribution into the network, perform, deliver care to their patients and impact quality measures. It's our intention to include them both in the reward plan and the PER. It's at the outset though, as we're contemplating launch, we're focusing on physicians at present for both the PER and the reward plan. With regard to Tanya's question about, are we discussing this with providers on weekly provider calls? Not our plan to talk about it during our COVID calls, if that's the weekly call you're referencing, Tanya, but absolutely our plan to engage all of our physicians on it. We've already presented this to our pediatric PCP advisory committee, which I believe every PEDS practice in AHP has a representative for, and our adult PCP advisory committee also received this information because we want, we're very much still in that design and introductory stage. We want their feedback. We want to make sure that this is fair, meets their needs, gives them, delivers the value that we hope that it will. So it absolutely will be discussed though on a greater level with all physicians who aren't, who are impacted by these changes, but may not be on these advisory committees. So excellent questions, and thank you for asking them. And I think I'm caught up on chat questions. So if we're all set, I'm gonna continue on to discuss the 10% citizenship component. So that's brand new, and I believe in one of our sessions presenting this, Kim referred to the citizenship component as a dream of mine. I assure you I have bigger, more ambitious personal dreams, but it certainly was a goal to include a citizenship component in our incentive plan, because the purpose of it is to incentivize behaviors that speak to meaningful engagement. We see in our years of experience working with your practices that the more a practice displays some of the behaviors that we're planning to reward under the citizenship component, the more successful they are in quality performance, the more successful, more positioned for the success they are under our value-based contracts. So we thought including this and rewarding that kind of meaningful engagement would be important and beneficial to the network. So I'm going to talk about what the components are. And I'm going to let you know that, first of all, the plan is to look at a practice first as a practice and see if the practice demonstrates these behaviors. And what we're looking for is for a practice to tick at least 2 boxes on this list. If the practice as a whole ticks 2 of these boxes, then every provider in the practice will earn that 10% citizenship component. If the practice isn't going to do that, if the practice isn't demonstrating that at present, then we're going to drop down and look at the individual providers to see if their individual behaviors relative to citizenship activities are ticking 2 or more boxes, and then the 10% component will be awarded to the individual physician that's done it. So let me run through what the components are, and then we'll run through examples. So for the practice level, those of you on this call right now are checking a box. Is that we would like practice managers to attend 2 or more of our practice manager meetings annually. In our years of experience, we've noticed that our practice managers that are very engaged, that come to these meetings, that ask good questions, that demonstrate an interest and engagement with AHP, their practices do better. You know, you're part of the team, you're an important part of the team. So your involvement with AHP is something we want to encourage and incentivize your practice for. The practice participating in a project like an optimization pilot, retinal cameras would be an example of that, or an administrative project, something like Vatica. Your participation in that would check the box for the entire practice. Pharmacy team engagement. You're meeting with our pharmacy team. You're regularly asking questions, or your docs are asking for lists of patients in order to switch them from one drug to a lower cost alternative. That kind of engagement. You have an active assigned practice champion. I believe we talked a little bit about this with your group, but essentially what we'd like to move forward with is a program by which you have a clinician in your office who's considered responsible to be the established official liaison, but responsible for the management of the relationship between AHP and the practice. That you've done that, you've assigned someone to do that, and that you're engaging with AHP clinical leadership around the PER. It comes out quarterly. Chad or LJ reaches out to your practice, wants to set up some time to go over it. You willingly accept that meeting. All of your providers attend that meeting, that kind of engagement. Now, I want to just include the caveat that what some of these really, how these boxes are ticked, we're still fleshing that out. The pharmacy team engagement, right? We're looking for some feedback from Erica and her team of what does meaningful pharmacy engagement look like, and what are those boxes within those activities. And as we establish those and we discover how best to measure those, we're going to continue to communicate to you what that looks like. Okay. So now moving on to the individual. So these are the components that will be considered when the practice hasn't ticked 2 or more of those boxes on the prior slide. When an individual provider in the practice has ticked 2 of these boxes, then that individual physician will be awarded the 10%. Attending clinical grand rounds or another AHP information session, allowing email communications. You'd be shocked at how many of your providers have clicked unsubscribe on our email communications. We want to encourage them not to do that. Serving as the practice's champion, accepting new patients at the time of incentive calculation will also tick off the citizenship box. Serving on a physician advisory committee, or serving on the AHP board or board committee. So what we hope we've demonstrated here between both the practice components and the individual components is that we want to give you lots of opportunities to earn this 10%. We've got a question about would would project participation count outside of AHP? That's something we can bring back to the team. The whole point though of these incentives are to encourage behaviors that have a direct impact on your performance with AHP. It would be unclear if any outside project participation would count for that, but we'd be curious to learn more, Jennifer, about the opportunity that you're talking about. So let me pause there and ask if there's any questions, and otherwise I'm going to move on to some examples, or just walk you through an example. Okay, great. So I want to walk through that first slice. So we're going to look at the practices first, right? It's time to sit down and figure out which practices are eligible for that 10% component of citizenship incentive. Practice number one, their practice manager attends 2 or more meetings a year, box checked. They're participating in Vatica, box checked. They regularly reach out to Erica and ask for patient lists, that box is checked. Practice one, by virtue of those high-level behaviors, has earned the 10% citizenship component for every provider in the practice by virtue of doing that. Practice two, however, is a solid line of red X's. They have done none of those things. So for practice two, we have to look at the individual providers. So these are the 2 physicians that are in practice two. Physician A is allowing email communications, possibly the easiest way to earn your citizenship component. And physician A is also serving on the adult PCP advisory committee. Physician A is going to earn that 10% citizenship component. However, physician B, as you can see, is less engaged and will not. So that is the totality of the citizenship component. Again, it's 10%. It's awarded first. We're going to look at the practice level, and there's lots of opportunities to earn it at the practice level, and then every provider in the practice gets that 10%. And absent those activities, we're going to look at the physicians. So that's the citizenship component. So in summary, before I turn it over to Christy, and before I turn it over and Bob Kiso then for a little deeper dive into that provider engagement report, just want to remind you of some of these high-level things. The reward plan that we just reviewed, the implementation is planned for 1/1/2022. I copped to this the last time we presented to it. I'm going to cop to it with this group. I was a little concerned about kicking this down the road. We were hoping to implement this year, or I was hoping. Our team was right to delay this to 1/1/22. We still have questions to be that we need to answer. We still have more opportunities to get feedback from all of you. So this takes place 1/1/2022 is when the clock starts on this new PCP reward plan. It's going to incentivize both the quality and cost performance, and then add that little citizenship piece at 10% to better align it with how AHP earns its gain sharing. That reward plan payment is going to occur in September following the performance year. So as the plan is currently laid out, if we're implementing 1/1/2022, the first incentive payment under the new reward plan will be September 2023. But those quarterly CI payments are flowing all along as they always have on a quarterly basis. You're still getting those, no changes to that. And finally, the incentivized measures and initiatives will be communicated fall 2021. Everything we showed you on the PER, we had readmissions, we had LARC, we had depression screening. That's not finalized. What we're going to be incentivizing and what'll be, the things we want to reward you for and what'll be on the PER, we will get you that final list and understanding fall 2021. And then finally, for the provider engagement report, it's going to replace the AAA report. We plan that you're going to start getting your first reports spring 2021 and then quarterly thereafter, late spring. And what really differentiates us from the AAA report is you're going to have instant access to actionable data with some patient level detail. Kim, as my co-conspirator here, I'm sorry I took over the summary. I was on a roll. Do you have anything you'd like to add?
No, you nailed it.
Before we turn it over to Christy? Okay. All right. Christy and Bob, I'm gonna turn it over to you. I'll stop sharing for now, and we'll turn it over to them.
Great.
Oh,
thank you.
Any other questions? Okay, great.
Thanks, Sam.
Go for it.
Good morning, everyone. I feel like we can start a game this morning where Kim has shown you all an early version of the provider engagement report and correlated it back to the various elements of the incentive plan. What Bob will be showing you shortly is a new version, the latest version. And I'd be curious to see how many differences can you spot. But what this illustrates is that this is a very collaborative and iterative process. And Kim gave me a lot of credit early on for, driving this, but I see this as a very large team effort, and you all are part of our team. We've already presented this to 4 other groups and are getting really good feedback on this and great questions that are really focusing us in thinking through some of the details of this. So the next section of the presentation here, Bob's going to walk you through our latest version. It's still in a prototype stage. We're designing it. We're taking feedback in. I've got some analysts that are working out data, trying to figure out what we have to be able to present that's meaningful and accurate. And also, we're going to be working on building a working prototype. So we're going to be coming back to you again as we have more to show and able to report some progress and get additional feedback. Ideally, we're going to be engaging all of you, even when it's released later on, continuing to ask for feedback. How's it working for you? And continue to mature this product so it supports you and us as we all mature through this journey. So I'll let Bob take it over from here. And thank you all for your feedback you're going to give us.
All right, great. I'll share my screen. I appreciate this opportunity to talk to everyone about this. Are you looking at a screen, the dashboard? Does everyone see that? Okay, great. First thing I'll do is I'll walk around kind of a mini tour of the dashboard so that we can understand all the elements at play. Along the top, you'll see that there's a masthead design. That's where we name the report, provider engagement report. You'll see in the upper left, and this came up earlier too. As far as it being quarterly, we would be able to share the information as the most recent, when was the data most recently updated. There is some discussion around that for different components. If they could be updated earlier, and maybe they often could be, we may redesign that caption. So you may see that on special, what we call data visualizations. In the upper right, we get into a profile area, and that is chosen at random. There's a practice name and a provider name, a stock photo in this case of the individual, and then the AHP logo. The other thing you'll notice in this area is what we call a toggle. Presently, it's set on practice, but an individual could, the user could toggle between individual and practice, and I'll show you that in a minute too. Moving down into the main area, you'll see 7 what designers could call cards or tiles. They're basically also data visualizations in a mini way, because this is a dashboard. The top one, cost quality, we talked a little bit about that, and some of the language has changed. Oh, maybe Christy, I'm giving these answers, but some of the language has changed in this area. And then along the next row, quality measure, and you'll see in 46%, and this involves this area known as being on target for a silver, needed to reach silver. Then in depression, we spoke a little bit about that. That's a simple parameters about patient, the number that have been screened within a total population. And then actually in those double arrows, each of those would allow you from this dashboard view to drill in, drill down, and drill through to get more information. I will show you in a minute readmission as one example. Moving along, we have citizenship, and we've talked about that. The other thing I will show you in citizenship, you'll see is that there's this quick win. And those are when we have the opportunity to share at the dashboard level some information that would be a quick hit, something that we could share before you drill through, we would do that. And in this case, attending, it gives you a very clear idea on how, in this case, the practice is only one away, 1 out of 2. So this would be an example of clinical grand rounds, could be something they could consider. Then moving down to the last row is readmission, and there again is a bit of a revise. So we've got that we're looking at with contacts 3, 4, and 5, displaying those measures of 42, 26, and 18%. Moving toward the middle, we have pharmacy that's on target, and for this particular prototype visualization, as is pediatric LARC. In that case, we're looking at three measures that are a yes or no: overall training, LARC placement training, and then last, any LARC actual placements performed. That is presently where that group is what we're looking at. The other thing that you'll see then, if we toggle between the two again, so we have practice and individual, this would show again as a prototype, we're showing that the maybe the particular provider wouldn't have a responsibility for LARC, so that one fell off. The other thing you'll see is that some of the color scheme, the green increased from the practice to the individual, because this particular individual we're showing is improved upon, has different measures and different results. The other thing we sometimes design in is conversational language at the bottom, which is sometimes called a footer. We're looking at, in this case, giving some quick, clear feedback, looking good. You're on target for 4 out of 5 initiatives, performance initiatives, with 3 months left in the year. So this gives, in conversational language, a pretty quick update to the that provider. From here, again, now, if we do a drill down, and this is just one example, we're in the process of designing all of these drill downs. But to give one example, if we were to go into readmission, what might that look like? And here's where we're at with the design today. For readmission, what we have in the upper left is a clear indication of it in a data visualization of the contacts 3, 4, and 5, and showing the contacts that are made versus total population that could have been made, 42, 26, and 17. That's where those numbers, percentages come from. And there would be a data table below that for more information. Moving to the middle, another component of information that would be nice to share may be the top 5 discharge diagnoses. In this case, you're seeing for that for the practice, what are those? As is the readmission, the actual readmission rate, which we talked a little bit about earlier. We could share that here on this in this particular screen. Also, what's very important is you'd have a patient list here, and you can, they're blurred out there, where the first column would say patient name, and then the information would be shared appropriately. And that is what I call a pretty quick tour walk around of the design of the dashboard and one drill through. Any quick questions as I've shared this, because I do have a couple questions I'll jump into, but I know I've talked rather quickly to present this. So any thoughts? Is this a quiet group? Oh, I don't know if I can see chats actually.
We have a question from Tanya about, is the report going to be available in real time on Arcadia? I'll let you answer that, Bob.
I think maybe that would be better for, Chrissy, I don't know if you want to grab it.
Yeah,
I know that they're companions. I do know that. Yes. Okay.
Yeah.
Right,
yeah. So this is not a replacement or even a direct connection to Arcadia. We will be pulling data out of multiple sources. Arcadia is one of them. But it's also not going to be real time. So where we might be pulling a snapshot on a quarterly or a monthly, we're looking at, some of the timing we have available to us on other data. Some things might be coming out more frequently, but Arcadia is going to be your most real-time system outside of your EMR. And we know that there's some delays there as well.
You know, when we first implemented the triple aim report, it was with the knowledge that the providers weren't, you know, logging into Arcadia every day or really even on the reg to check their performance. And we wanted the triple aim report to serve somewhat the same way your you know, monthly one-on-one with your boss does, or your report card in school, right? So at the end of the year, you're not surprised by the review you get. You're not surprised by the grade you get. We don't, and how this is even more of an improvement is that you're not going to be surprised by the incentive you earn, because that is something that was missing from the triple aim report, is that progress towards incentive. So I just, you know, want to point out that the whole kind of the purpose of these reports is that we understand that not necessarily are all the providers really, you know, logging into Arcadia on the regular and looking at the dashboard. And the Arcadia also doesn't include some of the aspects of this, right? Citizenship, the cost performance. I'll shut up now. Back to Bob.
Oh, that's good. Great. I could get into a first question then. And I realize, and Christy mentioned this, one day there would be actual prototypes, user-based. The user would be you, would be able to interact with this. And I realized it would be much better at that point to provide feedback. But at this stage, with the screens that I've designed, I have a few questions. And the first would be, knowing that this is a prototype, could you envision yourself comfortably interacting with this dashboard? That's my first question. Any thoughts when I say that? Ease of use, you know, that's what I'm asking, and I'm not sure. Let me see if I don't know if I can do the chats. If those, maybe somebody could read the chats in case those are comments.
Yeah, nothing yet, Bob.
Yeah. So, so what I'm often curious about is the degree of complexity. So I know when you're looking and you're familiar with these measures, but does the design give an indication of being complex, too complex? Any thoughts on this question about comfort level with this dashboard?
We've got a few responses here. It looks like it'll be easy to use, seems user-friendly, organized, another user-friendly.
Nice. Then as a follow-up, but like how can you envision yourself, how frequently might you be in a report like this? I realize the date it's dated quarterly right now, but as we develop this and when you see the dashboard, could you get a sense of if this is something you'd be in often or rarely?
We've got a couple more comments. Dashboard looks concise and organized. Looks like it'll be beneficial and straightforward. Monthly would be nice. As all reports like this, it's very important to offer data to a provider that can drill down to details. We always question the accuracy of the data.
Right. Okay. But and then
monthly at most, quarterly maybe.
Yeah. So that's still pretty frequent. As a dashboard designer, I would consider that frequent, and that is that leads into the next. My next question, and we sometimes use the word actionable. So the question here is, when you see these data visualizations, this dashboard, do you find the information to be actionable? In other words, we know what to do. I now know what to do. Any thoughts on if you feel that this provides actionable information you could act on? There are no voices.
Yeah, we've got another comment. Goal would be to access this at least monthly. Data integrity is always a challenge.
Right.
Back to your last question.
Right, previous. Any ideas on you review a visualization like this dashboard, and then we sometimes talk about actionable being, you know, the behavior changes. I know what to do. Any thoughts on that comment?
Nothing in yet.
Okay.
Yes, I've always
Not,
found Arcadia data difficult to read. This looks a little more understandable.
Mm-hmm.
I'm
Okay.
not primary care, but I can tell you that I do have a dashboard like this in an ophthalmology group that I'm in. And
Oh.
what I do is I click on the measure, see where it says 83%. It allows me to print a report that tells me what patients I've missed out on, whatever measure it is. And then I'm able to act on that. So yes, if your report tells people who they've missed and why they've missed it, then it would be able to be acted on to fix.
If there's a better, clear line from the, say in this case, the percentage to the patient list, that would be improve the actionable nature of this report. That's great.
Mm-hmm. Yeah, we got a couple
Okay.
more. Says you
Yeah.
could use this information and work the patient lists. Another one is viewing monthly would be able to act on.
Nice. So the frequency and the ability to interact with the patient list. That's great.
Patient would
Great.
need to show, or the patient list would need to show which patients are the incompliant versus the compliant.
Okay. Okay, great. I'll move to another question because this, you know, as designers, we sometimes talk about data being like cold or black and white, but this next question is what I call the emotional needle. So when you see a dashboard like this, do you ever have a positive or negative feeling? You know, where would your needle be, or is it a non-issue? Are you indifferent? In other words, some people say, oh, now, you know, this is very positive, people are going to be healthier. And then others are saying, you're guilting me by what you're showing me. Did any of you ever get a sense of this, where you could share your emotional needle looking at a prototype like this? Any thoughts?
We've got a positively intrigued.
Intrigued. So that often means that, you know, some people could spend a little bit of time there when you're intrigued, and the ability to drill through and to get into this information would mean that, to me, that would mean that, you know, there could be some valuable time spent on a report like that, like a dashboard such as this, when it's intriguing. Anyone to
Dashboard gives
expand
me a
on
positive personal response to investigate more.
Great.
We've got a couple others from the last
Exactly.
question.
Yeah.
Kira said, it would be good for our data coordinators to act upon, but it would not reach the providers directly. Human data interfaces will be needed to reach the provider. Kira, could you explain that a little more?
Yeah, we have data coordinators in the background that are in these types of, you know, software regularly with different payers, but it's not in front of the providers on a day-to-day basis. So it's not like they pull up their individual dashboard because they would have to log into another place. There's the issue. And it's not fed through, you know, the ideal would be to have it fed right into the EMR. When they turn on that patient person, they have their profile of what the patient needs are, or they have an overall profile of themselves or the entire practice. But that doesn't reach them at the point of where the impact can be made. It's still translated through data, through human interfaces, if you will.
That's interesting.
Okay, thank you.
Yes.
And we have another one here, action from Emma, actionable data that we can fix is easiest without having to sort through a lot of other things.
Okay.
That's great.
Streamline.
And then back
Okay.
to the emotions.
Yeah.
Valerie says, I love all my dashboards. I'm a competitive person, and the ability to see how we're performing and see where we can improve is exciting. Kira also said, a dashboard gives me a positive personal response to investigate more.
That's great. And the comment about the competitiveness, it's interesting. Sometimes as designers, these are called also scorecards or scoreboards, which is like a jumbotron. And if you go to a hockey game, you know, this is like, how are we doing? And you get all the parameters, how many shots on goal, you know. So this is, it's interesting whenever I hear that comment, because I've often looked at these in a similar fashion. It's great. Then moving along now, we'll making an assumption that there would be a base training, you know, so this wouldn't just be landed in your lap, but there'd be some training. When reviewing this dashboard, could you see yourself being here by yourself? In other words, some dashboards need a techie. Where's my help? Do you see that being here by yourself, or needing that assistance when you see these designs?
Dashboard looks user-friendly.
Right. Well, thank you. Yeah, good.
No, it appears easy to navigate and needing limited technical support.
Okay.
No support needed, looks reasonably intuitive.
It's good. Okay. I'm close to wrapping up my questions. I have a specific question for yourself upon login. Remember that toggle? See that toggle in the upper right area? Do you have a preference? Would you have expected it to be when you log in and it's displayed? Would you expect it to be on practice or provider individual? And I realize we're practice managers, but you know, what's your gut answer when I ask a question like this?
Practice. Non-providers would want to practice first,
Right.
first, practice.
Right. For the minute. Yeah, it's great.
Yeah.
Good. And last, when you know you've seen a lot today, I've presented. Is there anything that's hanging out there for you, like that's missing? Like I'm surprised he hasn't shown this, or they haven't talked about X. Anything hanging out there for any of you before I cut off these questions that's missing? Thoughts on that?
Nothing.
Or did we nail it?
Might have missed it, but are there patient lists exportable? So yeah, we will have the ability to export out to Excel.
Right.
And also be able to
Right.
print the pages out to a PDF if you wanted to save them or print them to share them in hard copy form.
Right. The application is actually called Tableau, for those of you who are familiar with that application term. And there's base functionality that Christy just mentioned with every report. Nice.
Yeah, and I have another question.
You do?
Because of the audience that we have here. How do you see this working in your practice? We know there's different engagement levels at the provider level. Is this something that you would primarily be acting upon? Who did you see being a heavy user of this? You know, we are prepared to, you know, give you all logins so you can see things at the practice level. And, you know, we've got to figure out exactly how we allow you to drill into each provider, but you will have that visibility. And would this be you or somebody else in your practice? Well, we get those coming in. There's a couple more. Said can we see the quality measure tab in detail? Actually, no, we haven't finished the design around that. This is just a placeholder. Our team is working with the data, and we have to go back with Bob and talk about the best way to present the information that's meaningful, especially as this isn't a replacement to Arcadia. We want it to be something that makes it easier to find information that you don't readily have available to you in Arcadia. Another question was, I assume it would be color coded. I find that helpful.
Right.
And then we've got, so it would be the practice manager and a practice champion for us as users. Mostly management running reports and delegating the reports to support staff. I can share data with providers as well. I try to only share summary information with providers, not lists. Be the practice manager for Penfield Peds. Here it says our data coordinator who manages all the data or the quality payment incentive payments with all insurance groups would be the main user. Tracy says I would be primarily acting upon, and this information is helpful to staff. Jennifer said it would be me and our PA, Kate, who would monitor this stuff. And Valerie said I use my dashboards monthly, run the reports, see where the improvements can be made and take action on them. Docs have never run them or seen them. I would assume practice admins and managers would be the ones to run and use the reports. And Andrea says it would be manager and population health coordinator working with the dashboard and then take info to the providers and the staff.
Oh, that's good.
This is all very helpful.
Yeah.
Appreciate the feedback
Right.
you all are giving us.
Yes, that, like I said, I don't know, Christy, if you have anything else, that concludes my questions. I'm really, I appreciate being able to share this level of early designs. I realize if I were you, I'd like to interact with this. We don't have that today yet, you know, and as Christy mentioned, one day that would be a, you know, a wonderful demo and moment to gain more information around interactivity and get these answers. Open quality measure that's coming. But so I'll cut off. I'll stop sharing now, and I really appreciate this information and being given this opportunity to share the work and hear your answers. Thank you very much.
Thanks, Bob.
Thanks, Bob.
Thank you.
So just to summarize, thank you for the review. We're still working on it. This is going to be a topic on our next practice managers meeting to show you the latest and greatest. In fact, we might have your initial version of the PER in your provider's hands before that meeting. But we will keep the PER and the incentive plan on this agenda to make you aware of our updates. So I'm going to move on next to our discussion of the 2021 quality measures. I'm going to turn it over to Willie Newdigan, and I will share my screen for him. So take it away, Willie.
Good morning, everyone. So as we close the books on 2020, I wanted to take a few minutes to provide an overview of the 2021 measures and the highlights, highlight any major changes. So adolescent immunization combo 2, which is a HPV, that's gone up almost 4%, but it's still relatively low at 39.9% for the 90th percentile. Breast cancer screening has barely changed. Combo 3 for childhood, up not even 1% at 87.32. Colorectal cancer screening up just over 1%. So no big changes there in the definitions themselves. Diabetic eye exam. The interesting change this year was the adding of the artificial intelligence interpretation for eye exam. I'm still digging into that a little bit more, but when the 2021 measure definition pages come out, we'll have more information on that. And that's actually, diabetic eye has gone down 0.25%, which is rare. And both the diabetic measures, the restriction was removed that only one of the 2 visits with the diabetic diagnosis be telehealth. So actually both can be telehealth now. Fall risk management. I said it's new for this year, but actually it's making a comeback. That's at 68%. Excelis is still working out some of the finer details of that. So expect more information within the measure definition page. The big changes were around blood pressure control. So the time frame for the diagnosis criteria last year was the current measurement year and the previous measurement year. This year, they're looking at the first 6 months of the measurement year. So if you're looking at a full year, it'd be January through June, and then the previous year. So it kind of negates the issue where a patient has been diagnosed with hypertension sometime during the previous year, and they come in December 15th, and they get diagnosed for the second time. There's no time to improve that person's blood pressure control. So that helps. The telehealth restriction was removed for the diagnosis. And the reason why they did that is they've added the telephone visits, e-visits, and virtual check-ins as appropriate settings for BP readings. BP readings can now be taken by any device. It doesn't have to be remote monitored. And the BP readings can be reported or taken by the patient. So those are big changes. Lead screening actually has gone down over 1%, which is a big help. Other than that, there's no other change. The well child 15-month, big change, the telehealth exclusion was removed. Unfortunately, they had it added in last year, which probably not a great year for that to happen. They removed it for this year. And then the depression screen and follow-up, there's no points for that again this year. We continue to work with you all, with the EMRs and with Arcadia to get that data mapped correctly or captured correctly before we even considered taking points for those. So when will you see these in Arcadia? So in the past, we waited for the annual Arcadia upgrade before showing the contracted measures for the upcoming year. In an effort to get your eyes on the effect of these measures sooner, we plan to have the measures available sometime this month with the new thresholds. However, the definitions will initially be the 2020 definitions. So the effects of the changes that I went over here won't take effect until the upgrade. So at least you'll get your eyes on it sooner with the new thresholds, but the changes won't take effect for the 2021 measures until that upgrade. And then of course, we'll let you know when that upgrade happens, since Arcadia's offline for about 5 days when they do the upgrade. The 2021 measure definitions, definition pages will be available on the AHP site next week. Once that's available, we'll make sure to add a link to that first page you see when you log into Arcadia. So right now you'll see the 2020 measure link. We'll have a 2021 measure link there as well. So lastly, I know I've worked with most of you on various data validations. If you have any questions regarding the data you see in Arcadia, please reach out to me. And I'm always available for a Zoom call and hopefully later this year for live visits if you need a refresher on Arcadia. Any questions as I zoom through that? Okay.
All right. Thanks, Willie. Appreciate that. Moving on, real quick, upcoming incentive payments. So what do we got coming your way? Our contract participating primary care practices. So clinical integration, this will be payment on your Excellus and MVP attributed members, $1 per member per 3 months for the quarter. And the quarter, this payment will be for the fourth quarter of 2020 that you will be paid on that attribution. So that is coming the week of March 22nd. These, for the most part, we have all of your information where we're able to pay you electronically, and then we'll follow up with an email that'll include the payment detail sheet as far as the per provider breakdown, and we'll also be including in that email hard copy, PDF of our quality measures that Willie just reviewed, and we'll continue to communicate with your providers about the 2021 measures. Quality incentives. So back to the beginning of our morning when we talked about our new reward plan. Well, the reward plan is taking place, is going to start 1/1/2022. So the payment that you're going to receive first week of April, that's going to be your quality incentive based on your 2020 quality performance. So this will be based on the current incentive plan, gold, silver, bronze, and we're going to be getting that out the first week of April. And then finally, the balance of 2020 gain sharing. So in December, I want to say, we paid practices a portion of 2020 gain sharing. We received the cash from the payers, a portion of the cash. We did very well in 2020. As you can imagine, the expense budget was pretty depressed due to the due to the pandemic, right? People weren't touching the healthcare system. They weren't obtaining care. So we did well under our value-based contracts, and we are going to earn a lot of gain sharing. So there was an initial payment on that 2020 gain sharing in December. The balance of it will be paid to you mid-August to early September. And again, that will be as well under the existing gain sharing payment methodology. There'll be a base, there'll be a per member amount on your attribution, and there'll be a quality component. So those are all of the payments that are coming your way in the coming months. Any questions for me on that, upcoming incentive payments? No? Okay. Well, then we've really reached the end of our agenda, and I always leave you with a reminder to make sure everyone in the practice knows that you are an AHP participating practice, and a reminder for your providers to, as best you can, refer to AHP specialists, hospitals, imaging, and labs. When we keep our referrals in network, we have our best opportunity to be delivering care based on shared clinical protocols and better communications. And we hope that you'll continue to do that. We thank you for everything that you do. It's been a hell of a year, guys. We're hoping for a much better 2021. Looking forward to having these meetings in person someday soon. And again, thanks for everything you do to contribute to AHP success. We couldn't do it without you. Take care, have a good day, and if there are no other questions, we'll release you all 7 minutes early to start your day. Bye, everyone. Take care.